I think for parents, it can feel overwhelming and scary to take your baby home for the first time. Even for me as a pediatrician, I took my twins home and was like, oh my goodness, they're letting me out into the wild with my babies. And so I think we could talk a lot to parents about newborns, but we try to counsel and reassure that when you go home, you're doing a lot of what you've done here.
The first 24 hours of a newborn's life are not just clinical, they're electric. They're where physiology meets fear and policy meets instinct, revealing how resilient and how vulnerable these babies can be. In this episode, we're unpacking what really happens in that first day. From the golden hour and early feeding behaviors to delayed bathing and recommended care. The first day is where pediatrics begins and where families are set up to thrive. This is Charting Pediatrics. For this discussion, we are joined by Doctors Anna Ruman and Christine Gold. Dr. Ruman specializes in pediatrics here at Children's Hospital of Colorado. She is also an assistant professor at the University of Colorado School of Medicine. Dr. Gold specializes in pediatric hospital medicine and is an associate professor. Anna and Christine, welcome to the podcast.
Thank you for having us.
It's exciting to have you guys here. We have some background. Christine, you and I used to work together in the child health clinic. Anna, you and I trained at the same amazing residency program, Mass General in Boston. This is a cool time of life. It's the beginning of life for little babies. It's so exciting, and there's so much that happens. When does a pediatrician become involved in the first sort of moments or day of life for a newborn?
That's a great question, Dan. So first of all, about 10% of births require some kind of resuscitation for the newborn. And so we are often present, even if not many risk factors are identified for the birth itself. So sometimes we are very privileged to be present at the time a baby is born. However, in kind of an uncomplicated delivery, especially a vaginal delivery, the infant would typically go skin to skin with the birthing person right at the time of delivery. And that is one of the most important things for early establishment of breastfeeding. So the infant goes skin to skin, they're warmed and dried, a hat is placed, and then we and the labor nurses leave the infant in the company of the birthing person for at least that first hour. It's a very sacred time. And so we as pediatricians and pediatric care providers try very hard not to disrupt that time unless there's a reason to intervene or examine the infant in some other way.
Is that also known as kangaroo care?
It is part of kangaroo care, absolutely. Okay. And in addition to being critical for early establishment of breastfeeding, that kind of golden hour skin-to-skin time is very important for thermoregulation and avoiding early hypoglycemia.
Okay, great. And so once, the baby's born, gets established, skin-to-skin care, when does one start trying to breastfeed the baby?
Yeah, so the baby is sort of the boss when it comes to that. So ideally, breastfeeding is attempted in that first hour, and that has been linked with higher rates of breastfeeding at the time of discharge from the hospital. And so if a baby is showing cues and is ready to breastfeed in that first hour and the birthing person is able to do so, we get that started right away. And most hospitals have a labor nurse or a pediatric admit nurse who helps facilitate that if needed.
So we do have some parents that actually listen to our episode. I have 3 kids, and so I remember their mother trying to breastfeed them. In the beginning, it wasn't so easy. Are there things or ways that you can sort of enhance the ability for a mom to breastfeed, or maybe it's just about counseling that it takes time? I don't know.
One of the greatest misconceptions we find with parents is that the baby will be born, they'll latch to the breast, the milk will start flowing, the end. And really, that's not reality. The milk supply takes days to come in. A baby does have a suck reflex, but may or may not latch well to the breast, depending on the birthing person's equipment. And so one other thing we often see is that a baby may breastfeed once or twice in the first 4 to 6 hours, and then it's like it hits them that they have been through labor too, and they're tired, and they shut down and sleep the rest of the day. And we often find parents are very surprised and worried about that, but that's normal feeding behavior.
And just to add to that, for those of you who care for infants and families outside of the newborn nursery or hospital setting, I think some of the setup for successful breastfeeding in families that desire that begins before the family is admitted to the hospital for the birth. So I think it's important, especially for those of you who are primary care providers, to know whether your state's Medicaid policy covers a breast pump, and to support families in being able to access a breast pump prior to the birth of their child. And in addition to pre-enroll eligible families in WIC, because depending on the state, the wait times for WIC support can be quite long. And so that's another thing we do see is that, in addition to what Christine mentioned about just some of the early challenges of breastfeeding and parental expectations, some of the resource constraints at the beginning can set families up for a lower chance of success with breastfeeding as well.
That's great to know. So we have so many listeners here in Colorado. What is the situation with that in Colorado?
So in Colorado, it depends on the person's insurance coverage, but Medicaid in Colorado does cover a breast pump, and patients and families can access that breast pump and have it prior to delivery of the infant. And then most private insurance also covers a breast pump. And so, we, of course, in the hospital provide a hospital-grade breast pump, but we all know that some patients and families go home with instructions to supplement, which I imagine we'll talk about later, and they're going home without access to a pump at home. And I think that that's a big challenge. And then the current wait times for WIC in our state are weeks to months. I imagine that's similar in other states. And so I always worry about families who have not been pre-enrolled in WIC, because it's going to be weeks after the birth of the infant before they'll have that intake appointment.
It's really good to know. It harkens to, you can actually have a prenatal visit at a primary care medical home, and that might be an opportunity for some of these things to take place. And you mentioned breast pumps, and I think those can be really advantageous. I also know that there's different types of breast pumps. And do the commercial insurers and also Medicaid cover only manual pumps, or do they also electric pumps? Christine, you're nodding your head.
So they should be covering electric pumps as well. And, if someone does get one prenatally, they can bring it into the hospital if they want to know how to use it. And also, as Anna pointed out, we have the electric pumps in the hospital for parents to use, which is important because some babies, whether they're preterm or if a birthing person has complications after birth and they can't directly feed at the breast, we'll get them pumping with our equipment just to get that milk supply established.
And I was recently talking to one of our lactation consultants about measuring for flange size for breast pumps and asking if that could also be done before that initial visit in the hospital. And apparently any time in the third trimester is a reasonable time to measure. And so sometimes patients and families, especially people with different anatomy, bring their own breast pump, but they don't have the right sizes of flanges. And that can also be very stressful. And so that's another thing that a primary care provider can support a family with, again, and just making sure they have all of the equipment set up as well as they possibly can before the newborn is born.
That's helpful. So we've talked a lot about sort of what happens immediately after birth in terms of skin-to-skin contact. We've talked about some things that maybe can be in place before birth, maybe WIC, maybe breast pumps. In the first 24 hours of life, maybe even in the first 48 hours of life, one of you had mentioned that, the baby after a couple hours is like, whoa, what just happened and where am I? Type of thing. And obviously mom's going to be really, really tired as well. What would be a normal pattern of feeding in the first day of life? And when would you be concerned that something's not right?
A pretty typical pattern of feeding, like Christine mentioned is, maybe that initial feed during the golden hour, the infant is alert, latches, everyone's feeling great about how things are going. And then the baby gets very tired and maybe is trying to sleep the rest of the day or the night until the 24-hour mark. So we do recommend continuing to wake the baby to attempt to feed during those first 24 hours, offering the breast every 2 to 3 hours, or engaging in offering feeding every time the infant is cueing. But just to know that many infants are not actively cueing because they're so tired. So we don't want to let them sleep for 12 hours during that first day of life. They're cueing. We want to follow their cues and offer with hunger cues. If they're not, wake them about every 3 hours. Don't let them go longer than 4 hours without offering some sort of nutrition. And the initial kind of quantity or volume that a newborn needs in the first 24 hours is also very small. So sometimes we tell families like the amount of colostrum that they're getting each feed, we expect that to be about the size of, the volume of a teaspoon or 5 milliliters. It's very, very small. It might just be drops, right? And that colostrum is both very high calorie and also very rich in immunoglobulins, important for the infant's immune development. So if anything, we mostly provide, I think, a lot of reassurance in the first 24 hours of life that this is very typical behavior. We expect your baby to be sleepy. We do want them to be getting at least this little bit of nutrition during the first 24 hours. And I often encourage families to take that time and rest, because sometimes the baby will be what I sometimes call a party baby after 24 hours. So they'll wake up, they'll start cluster feeding. Again, very normal behavior, but can be very hard for a new parent who's very tired.
Yeah, sleep deprivation is no joke. So that's really helpful. What would be any kind of, let me ask first, how long should a mom give it kind of the old college try in terms of putting the baby on to latch? Of course, you're looking for those, the little sounds and, mom's feeling stimulated. But how long should the baby be on the breast attempting a breastfeed?
Well, I think it depends on the baby, because when we have babies who are more medically fragile, especially preterm babies, we are pretty quick to limit unsuccessful attempts, meaning we're trying to get them to latch and they don't, or they get on there, but you don't hear swallows. And so we will limit unsuccessful attempts in a preterm baby that we still care for in the nursery to maybe 5 to 10 minutes, perhaps. I would say that older babies, as they get better at breastfeeding and they get more milk through the first few days, they are expected to be efficient feeders. So when you get people who are telling you, I've had the baby on here for an hour, look how great they're doing, that's actually a red flag for me, because an efficient feed should happen within 20 to 30 minutes. And so if we're taking an hour plus and we've got a really sleepy baby, it makes me worried that we're not doing well.
And sometimes when families say, oh, yes, the infant's been at the breast for like 45 or 60 minutes, it can be really helpful for one of us, the lactation consultant or one of the postpartum nurses, to observe a feed, because I would say at least 80% of the time, what's actually happening is the infant is actively feeding for a pretty short amount of time and then falling asleep at the breast or using the breast for comfort, which is wonderful. But it's helpful to understand what the actual duration of feeding is versus just the duration at the breast. And as Christine said, there are many scenarios for more medically fragile infants where we limit their time. I often tell families, this is exercise for a baby, right? Like it takes a lot of energy and calories for a baby to breastfeed. And so, if there's some reason that we're concerned about their weight gain, or if the baby has some other kind of medical condition, those would be situations in which we might limit that time.
I just want to take a moment to call something out. I mean, breast milk is great, and it's great for the mom's health and also for the child's health, but it doesn't always work out, and that's okay. A lot of families either choose formula feeding, or for physiologic reasons, the baby needs to take formula, and that's totally okay. So I know we've been focused on breastfeeding, and breastfeeding is great, but just wanted to normalize and say that, bottle feeding with formula obviously is a very acceptable and nutritional way to feed your baby. And listeners out there, if you want an episode focused on formula feeding, let us know, write us. But back to our conversation, we were talking a lot about sort of what the intake was. Maybe we should talk a little bit about what we expect in terms of elimination in those first 24 hours.
Great question, Dan. So we really just like the first void by around 24 hours of life, and really for sure by 48 hours of life. We would not discharge an infant that has not voided in life. Sometimes families get really worried at 24 hours. Most of the time, if the infant otherwise looks well, we think has had good intake, and we don't have any concern for any anatomical abnormality based on prenatal ultrasounds, we continue to watch until 48 hours and then get a renal bladder ultrasound at that time. For stooling, kind of similar, we like one poop by the first 24 hours of life, but definitely by 48 hours of life. And again, if that's not happening, if the infant's abdomen is distended, if they're vomiting, if they're ill appearing, then we worry more. But the way I usually summarize it for families is we are just looking for that one pee, one poop by about 24 hours of life, but it's not a hard and fast rule.
It's really helpful.
Yeah, and I think parents are often surprised about how much stooling is in the first day versus urine output, because they go to the parent classes perhaps and they learn, a baby voids 5 to 8 times per day. And we're like, yes, but the first 24 hours of life, they stool a lot more than they void. And that's appropriate for a baby who's been storing meconium for about 2 trimesters worth of time to get that all out in the first few days.
And sometimes when we don't see a first void, it's important to check with parents that no one accidentally threw away a diaper. I would say at least half the time that's the case, kind of practically boots on the ground. A lot of new parents don't know about that little blue line on the front of the diaper. That means it's a wet diaper. So that's often the first thing I'll do practically if we haven't had any wet diapers is double check that no one's thrown one away on accident.
That's very helpful. So what about kind of medications and other routine care in the first 24 hours of life?
Yeah, so medications are an important part of the newborn's first day of life, and we don't interrupt that first golden hour to give those medications. We really want that to be the sacred, uninterrupted time. But we do recommend the medications to be given shortly after that so that there's time for those medications and vitamins to start working in the baby and protect them.
So what are some of the things that we give?
So we still give the hepatitis B vaccine at birth. Again, all of this requires parental consent, and we're happy as pediatricians to review why we do these medications. But hepatitis B vaccine, the erythromycin eye ointment, and then very importantly, the vitamin K injection to reduce the risk of that baby being at risk for bleeding as babies are born deficient in vitamin K.
And erythromycin eye ointment is for?
So that's for eye disease caused by the bacteria that causes gonorrhea. So it's very specific. A lot of parents say, hey, I've gotten those tests and I don't have that, and they decline that, and that's a choice to make, but we'll still counsel on why we give it. So.
Yeah, good. And I think a common misconception is that it's also covering for eye disease caused by chlamydia.
Right. We spend a lot of time teaching our residents and students
That's right.
that that's a misconception.
That's a misconception,
Absolutely.
Right? So as pediatricians out in the primary care world, we need to be careful when trying to discern, a conjunctivitis caused by a bacteria like chlamydia from nasolacrimal duct stenosis. So understanding the background, what happens in the nursery is really important for us too. Mm-hmm. And I appreciate what you said about vitamin K and hepatitis B as well. What are some of the other things we need to think about in the first 24 hours of life? Is that about it? Are we now at 24 hours of life, or tell our listeners about?
Not quite.
We're not there. We're not there.
Almost
okay.
there. So a question that often comes up from families and for which hospitals have different practices is timing of first bath. So the AAP now recommends to delay the first bath until at least 24 hours of life. That thick white coating that newborns are born with called vernix actually has great antimicrobial properties. And we also avoid early bathing due to risk of hypothermia. If a family opts or requests to have a bath before 24 hours, we recommend waiting at least 6 hours. But really, the things that newborns are supposed to be doing in that first 24 hours are that kind of establishment of basic feeding, first pee, first poop. And that's what we hope for from them at that time. Then we move on to some 24-hour checks that we'll talk more about.
I graduated residency in 2007, and I remember going to a lot of births, and we would dry and stimulate the baby, often on the, the warming table. And as I recall, we were almost like trying to get the vernix off. Is that different now?
Well, I think we still see that happening in births, but the point of the drying is to stimulate the baby. It's not to remove the vernix for cleanliness reasons or something that's actually really healthy for the newborn skin. And so I think the drying and stimulation, when indicated, does impact the amount of vernix left on the skin, but we want to leave as much intact as possible.
Amazing. So we've talked about the golden hour. We've talked about the establishment of breastfeeding. We've talked about medications that we give, and we've talked about bathing. So are those all the things in the first 24 hours of life, and now we're at 24 hours?
I think for the well newborn who requires no additional care, that's a reasonable place to stop with that part.
So what happens when the earth spins one time, 24 hours? What happens then?
Yeah, so 24 hours in the newborn's life, we celebrate as pediatricians. And I always tell parents that I care about every moment of their newborn's life. But at 24 hours, we get more data on the newborn. And that helps us to understand how well the newborn is transitioning from being a fetus to being a newborn. And I can go through some of those things that we do.
Yeah, please do.
So one of the most basic things we do at 24 hours is we reweigh the baby, because we know all newborns lose weight in the first day of life. Sometimes our parents are surprised to hear that, but there's an expected amount of weight loss. And Anna, I would say probably 4 to 6% weight loss in the first 24 hours for our breastfed newborns. Yeah. It's very common. And so that helps us understand if we have to make any changes to the feeding plan, or at least recommend changes to the feeding plan, that sort of thing. We also at that time assess for jaundice in the newborn, which can be done with a little skin light sensor that we place on the newborn. We check oxygen levels to make sure, what we call the CCHD, or critical congenital heart disease screen, to see if oxygen levels are similar and appropriate across different spots on the baby's body. And then lastly, we do a blood draw for the newborn metabolic screen, which is different in every state, but every state has some sort of list of diseases they test for. And in Colorado, we test for things like inborn errors of metabolism, hemoglobinopathies, cystic fibrosis, that sort of thing.
So is there anything magic about that one revolution of the earth? In other words, does it have to be exactly 24 hours? Do you kind of go in and wake up the baby if the baby was born at 2 a.m.? Do you also have all of these things done at about 2 a.m. in the middle of the night?
That's actually a practice that varies by hospital. Many hospitals where babies are born, or other places where babies are born, stick pretty close to that 24 hours. There are a few of these tests that if they're not performed at 24 hours or later, they have false positives and false negatives. So CCHD screening, we recommend waiting until 24 hours of life.
Do you mind just telling our listeners what CCHD stands for?
Oh, yeah. Critical congenital heart disease screening.
Thanks.
So our CCHD screening, we recommend waiting until 24 hours of life. A lot of newborns, just as part of their physiologic transition, especially at altitude, are mildly hypoxic for age in the first 24 hours of life. So that we definitely recommend waiting until 24 hours. And then the newborn metabolic screen is not validated in most states before 24 hours of life. So that is also, the aim is to do it as close to 24 hours of life as possible.
Yeah, so I'll add that for those reasons, we have medical reasons why we wait until 24 hours to do those things, that we typically counsel parents that they should expect to remain in the hospital for at least the first 24 hours just to achieve those things. There are times where for a particular family that might not be feasible or wanted, and then we will still complete some of the things we just discussed at 24 hours. We'll do it a little bit earlier before they leave the hospital, but often we'd recommend that the CCHD, the jaundice level, get repeated with that baby's first pediatrician visit.
And depending on the birth setting for the infant, some of you listeners who are primary care pediatricians may be performing this initial 24-hour assessment in your practice. And so if that's the case, these are the recommended screenings. It is worth also mentioning, just for evaluation of jaundice. Certainly if an infant has jaundice before 24 hours of life, that's worrisome. And if an infant ever appears jaundice before 24 hours of life, we actually just go ahead and check their bilirubin right then. We don't wait until 24 hours.
So I think we've been talking about some standards of care and kind of best practices in this setting. We live in a resource-rich setting. Not all of our listeners live in resource-rich settings, but I think it's helpful to go through, what we think is the best practice and standard of care. Now you're at the moment sort of where you're getting your baby ready to go home. What are the, not every parent may be able to bring their baby in right away, a day or two after, which is the standard of care, right? To see a primary care pediatrician. What are you guys thinking about in terms of, I feel good about this baby going home? And what should parents think about once they're at home as I know we can't cover everything, but just some big picture things.
So some things we think about and go over with families about kind of discharge milestones for the well newborn would include a lot of the things we've already talked about. So some kind of feeding method being established, having voided and stooled in life, not having excessive weight loss, which we usually define as more than 7% at 24 hours of life, more than 10% at any point in time, having passed these 24-hour assessments. And then we could do a whole episode on this, but having resource and mental health needs met, I think, is a really important aspect of care. So social needs screening performed in the newborn setting, availability of a car seat, other social emotional family supports, et cetera. All of those things being in place before discharge readiness is discussed. And the usual timing of follow-up that we recommend is usually somewhere in the 2 to 3 day range. It depends on how worried we are about a baby's feeding, a baby's weight, bilirubin, some of these other things. Anything you want to add?
Yeah, no, I agree with all of that. And I think I'd love for outpatient pediatricians to know that for us caring for the newborns inpatient, it can be really tricky for the same family you might have cared for that you're discharging on a Monday versus you're discharging the same family on a Friday of a holiday weekend. It can be really tricky about how you manage things because they may not be able to access care for several days. So we really may tweak the hospital plan if we need to, depending on access to care. I think for parents, it can feel overwhelming and scary to take your baby home for the first time. Even for me as a pediatrician, I took my twins home and was like, oh my goodness, they're letting me out into the wild with my babies. And so I think we could talk a lot to parents about newborns, but we try to counsel and reassure that when you go home, you're doing a lot of what you've done here that we had oversight over. So things like you're working on feeding, you're watching output, you know your baby best. If they are not waking up and telling you they're hungry, if they're just not acting right, here are the places you could go, the people you could call to get that care. But we're just going to repeat what we've been doing for the next couple of days until you see your pediatrician. And that's the way we sort of pump up our families to hopefully feel confident about what they've already been doing and get them to that first pediatrician visit.
Yeah, I think from a primary care point of view, it's nice to get them established as soon as possible, but it's got to be within reason, right? Like if the family goes home one day, do you really expect them to see you the next day? That might be a lot. I mean, it's amazing how overwhelming it can feel to bring a baby home. And then, yeah, logistics like long weekends and stuff. I really appreciate you saying that, Christine. So I think from a primary care medical home point of view, the earlier you establish care with a patient, then you've got them, then they're established with you and you can care for them. So I think that's really important. All right. Well, I think we've covered a lot of territory. First 24 hours of life, which is so exciting and just such a meaningful part of, a meaningful part of a family's life, and to be able to be there for families is pretty special. We always like to end our episodes by asking, what is your favorite part of what you do clinically on a daily basis? Christine, why don't you go first?
Yeah, I think with our line of work, I love the combination of acute care, primary care, hospital medicine all in one, and just working with families at this really special time in their life. So can't get a better job than that.
And I love accompanying patients and families through some of the most joyous moments of their life and some of the hardest moments of their lives. And it's such a privilege to be there. It's like a very lucky thing to be able to be there for patients and families, especially in the newborn space is really special.
Yeah. Well, thanks for all you do, and thanks for being here.